Alrighty, we are live. Welcome everyone to Healthcare Happenings. These are weekly events that I host to touch base on what I'm seeing in healthcare from the front lines. The past couple of weeks, I've been uh, splitting up what I've been talking about based off of themes. So this week we'll be talking about artificial intelligence, and there's a lot to discuss. So let's dive in. But before diving in, let's see any recaps from this week. I guess 23andMe filed for bankruptcy. No surprise there. I talked about it the other week. Um, so good luck to them. And then this morning in the Inefficiency Insights newsletter, where I talk about inefficiencies I'm seeing firsthand, I talked about ghost networks or phantom networks, and the reason why insurers are basically not incentivized to keep their provider directories up to date. But in regards to artificial intelligence, I think about four things I wanted to discuss today, and honestly, maybe even get your thoughts on moving forward. So first, Open Evidence and the New England Journal of Medicine formed a multi-year contract, and this contract will give Open Evidence basically access to all published content and multimedia that's been published on New England Journal of Medicine, New England Journal of Medicine Evidence, NEJM AI, NEJM Catalyst, NEJM Journal Watch, all of the New England Journal of Medicine's like different verticals of publications, and Open Evidence can basically use the content as training data, which will, I don't know, I think make the platform even more robust. Of course, it will also introduce bias if a majority of the training data is coming from NEJM. Uh, I mean, this is paywall content at baseline, so and only the top quality journals. So you may be missing um, some of maybe not the lower yield stuff, but stuff that's not as prestigious, but still may have a high impact. I use Open Evidence, as you know, all the time. Um, it's now becoming like my main go-to platform for staying up to date on um, just like medicine and like searching responses and medical questions rather than using like up to date, which was what I used before, where I would just like search or have a question in mind and then do my own research. Open Evidence really helps streamline that. Um, uh, I'm not sure if Open Evidence and Up to Date use the same, I don't know, like training data or the same knowledge base, but I'm not using Up to Date as much anymore. So I imagine others are in the same boat if they're using Open Evidence, and it may become obsolete, but we'll see. Next, Accenture, the consulting firm, surveyed 300 C-suite executives on um, basically generative AI and what they think the biggest use case is, and what they think would be the biggest impact of generative AI for their workforce. So, for the question, like, what do you consider the biggest opportunity is for generative AI in those organizations for these healthcare C-suites people? A majority said to increase employee efficiency and drive revenue growth, which I agree are two uh, areas that generative AI can totally tap into. Um, and then when it comes to like what the impact is, of course, they said they think revenue growth will be very impacted by generative AI, as would be productivity gains. But lower down on here is error reduction, and I actually think the generative AI platforms have a big role to play in regards to error reduction. You imagine that generative AI can basically be reading the prescriptions we're writing, detect if like we wrote something wrong, if there are any errors, could correct it, and so forth. So I actually think there would be a big opportunity for error reduction. And of course, the goal is to drive revenue. Whether that will be feasible, we'll see. Which is a good segue into the next topic. The Peterson Health and Technology Institute released like their preliminary report on like the effectiveness of ambient scribes, right? So we've talked about ambient scribes before. It's these large language models that are listening to patient physician conversations and basically using those conversations and seamlessly incorporating it into a soap note or something similar. Um, Unlike other digital technology over the past couple of years, which have taken a lot of time to integrate into workflows, generative AI has really hit the market by storm, and we're seeing pretty quick traction among these ambient AI companies that are getting into major health systems like Kaiser, um, Ochsner, Mayo Clinic, MGH, right? Like pretty prestigious institutions are already implementing these generative AI models, ambient scribes. But for background, as physicians are burned out. There's a huge documentation burden, partly for like defensive medicine and billing practices, and it's just taking a huge toll on providers. I'm an outpatient right now, and just doing notes over and over again, really driving me insane. But not so much of notes, just the admin stuff outside of it, like needing to figure out how to get a patient DME, et cetera, et cetera. Um, and the way these ambient scribes work, basically, they listen to a clinical conversation, and then using this like automated speech recognition model, it can create a transcript. And from that transcript between the patient and physician, it filters it into a large language model, which has been trained on how to basically write notes and figure out what the important stuff are. And then it creates that clinical note into the EHR, and then it's updated in the EHR node, and it's up to us, the physician, to figure out if this is accurate or not. So that's how it works. And there's a bunch of different applications for these ambient AI technologies, right? You could have it for documentation, revenue cycle management, CDS, which I think is huge, and chatbots. So totally opportunities to not only increase productivity, but increase revenue as well. So the PHTI try to gather as much data possible to really make some sort of determination over if clinical or these ambient scribes are meaningful in a cost effective and productivity manner. So I'll go through it. They basically broke everything down into impact areas from clinician, patient, and financial. And I'll tell you what basically the final result was. So for clinicians, attrition, too early to draw conclusions. Burnout, emerging evidence suggesting a positive impact. Clinician experience, mixed feedback. Clinician time saved, mixed feedback. Cognitive load, emerging evidence that says this is good. Pajama time, mixed feedback. And then quality of the clinical note, evidence saying that there's a positive impact, especially when there's a human in the loop. For patients, patient experience, emerging evidence saying that there's a positive patient experience. And financials, too early to tell if um, there's a good return on investment. And when they asked some people and some of the stakeholders holders for feedback, they basically said that the generated notes didn't reflect their personal style or voice. They had minimal time or bandwidth to engage in the adoption process. They've already optimized their note taking process, so adding ambient AI really wouldn't change much. Or there was just like some language barrier, like the large language model couldn't support the languages that they needed, which I think is interesting. But in my personal opinion, I don't know if I'm a big fan of ambient AI. Perfectly because like that feedback, like I already have a pretty robust system for note taking, pre charting. That by the time I'm seeing a patient, my note is already done. I'm really just having a conversation and making sure that I'm not missing anything. So to actually have ambient AI listen to my patient conversation and then create a note after, then I have to review it as if I'm reviewing a medical student's note, that kind of seems even more inefficient for me. Where I would really like to see generative AI and this like ambient AI technology is with like the ancillary tasks that I need help with, right? It's like getting a patient an appointment, refilling medications, getting a patient DME, writing prior auth letters, writing, medical necessity letters. Like these things that take a lot of bandwidth for me that are just not something I need to do. Filling out M11Q forms, right? Filling out home health aid for like all these things. I think AI could actually have a bigger impact. And I guess you could loop all this into like inbox management. I think inbox management is a huge area that can use uh, ample productivity increases, to say the least. Which brings me to the last and final news is Innovator or Innovator. I don't know how to pronounce this name, but they this AI company release a host of AI agents to basically automate scheduling, patient intake and referrals. Basically, everything I just complained about, they do. Um, and their goal is to create these like AI agents that can really tackle the low hanging fruit. Um, Again, scheduling appointments, collecting information, basically using AI to automate the work, the busy work that physicians just don't need to be spending a lot of time on. I would expect that this market is soon to become saturated with AI agents. Um, Maybe these companies will sell them in bundles, etc. But I'm hopeful that by the time I'm starting to practice on my own, we'll have pretty robust technology taking care of the annoying stuff that we have to deal with as physicians. All right, so that's all the news, AI news for this week. I'll see you next week, where I believe I'll be talking about healthcare policy. All right, see you in your inbox on Sunday for the next Health Grounded newsletter.